Please start the presentation.
Okay. Good evening, everybody. Today case discussion is on abnormal uterine bleeding. So we have a patient named Mrs. XYZ of age 26 years old who hails from Mangalore, and she is a maid and has an education status of up to 4th standard, and she hails from lower middle class and she's unmarried. She was admitted on the day of 20th April 2020 and she was examined on the day of 23rd April 2020. She comes with a chief complaint of pain abdomen since 1 year, heavy menstrual bleeding since 6 months, and pain during menstruation since 6 months.
Okay, continue.
History of present illness. Patient was apparently normal 1 year ago, after which she developed pain in the lower abdomen. It was insidious in onset and gradually progressive. It was dull aching in nature and it radiates to the back and the thigh. It aggravates 3 to 4 days before menstruation and is relieved on medications. It also reduces after stoppage of bleeding. A patient also complains of
Yes.
Patient also complains of heavy menstrual bleeding since 6 months. She uses 6 to 8 sanitary napkins per day. This is now. The previous menstrual history I'll be dealing it with later. She complains of waking up at night in order to change her pads. There is no history of passage of clots, and she also complains of pain during menstruation since 6 months.
Okay.
There is no history of abdominal mass, no history of burning micturition, increased urinary frequency, or urinary retention. There is no history of constipation, no history of vaginal discharge, no history of fever, cough, no history of any significant weight loss. Coming to the previous menstrual history, her last menstrual period was on 7th of April 2020. She attained menarche at the age of 12 years. Her cycles are regular of 28 to 30 days. She uses 3 to 4 sanitary napkins per day. Now, no passage of clots and no history of dysmenorrhea.
Okay, wait here. Come back to the previous menstrual history. Okay, beginning thing. You gave introduction to the patient, no? Their name, age, and all. Better to include LMP there because we wish to know LMP first. It gives a clue for us to proceed with the case. Okay. Go for the next slide. Yes, chief complaints, pain abdomen since 1 year, which you described more like a dysmenorrhea, right?
Yeah.
It is relieved on medication and just prior to the menstruation, it aggravates. Correct, no?
Yes, sir.
So you can just keep it as simple as heavy menstrual bleeding and dysmenorrhea or pain during menstruation. And you can remove that separate pain abdomen. That's a little confusing for us to know. So if you keep only heavy menstrual bleeding and pain during menstruation, that keeps the case very simple. We can come to diagnosis very easily. Okay?
Okay, sir.
And heavy menstrual bleeding, have you described? How is the bleeding?
Only during the cycles there is heavy menstrual bleeding.
But how will you describe a menstrual cycle?
With the duration of the cycle and the amount of bleeding.
No, complete. How will you describe a menstrual cycle? From we'll start whether it's regular or irregular. Once in how many days she is getting the cycle? How many days flow is there? And how is the flow? Whether it's heavy or associated with clots or dysmenorrhea, right?
Yes.
Okay. In same way, you have to describe the heavy bleeding as well. So since 6 months, she is having heavy bleeding. So how is the cycle? Once in how many days she is getting the cycle?
The cycle is regular, 28 to 30 days of cycle itself.
Same,
but the
28 to 30 days cycle. Okay.
But the amount of
flow is only increased.
Yes.
Increased. Okay. There is no increased prolonged bleeding also is not there. Only heavy bleeding is there.
Yes. No prolonged bleeding.
Okay. So these are the new terms we are using at present. Previously we had menorrhagia, all these terminologies. So presently we use, what are the present terminologies?
Abnormal uterine bleeding.
No, that is different. That's a diagnosis. So for menorrhagia, we use it as heavy menstrual bleeding, or it can be a prolonged menstrual bleeding, or it can be heavy and prolonged menstrual bleeding. Okay, these are the new terminologies we use, which are simple layman terms, and it will not confuse us regarding what is the presenting complaint, right?
Yes.
Is there any way to know whether the bleeding is really heavy or not?
The
What
amount
teachers
of
suggest? Yeah.
the amount of sanitary napkins she changes per day can indicate the
Okay.
amount of bleeding she's having.
How will you know she's changing when it's fully soaked only? She may be changing partially soaked pad also, no?
Passage of clots also can indicate.
So you told 6 to 8 sanitary napkins, right? So if it is like
Yes.
slightly soaked and she has say change 6 to 8 sanitary napkins, it will not amount to the heavy bleeding, right?
Yeah. Oh yes.
Then, okay, there is something called pictorial representation of menstrual flow. Okay, so just know that it exists, in which we give scoring for each thing. Whether the pad is fully soaked, partially soaked, or just soaked. Then what is the size of the cloth? If it's 1 rupee coin size or it's less than 1 rupee coin size, there are different scoring for that. And episodes of heavy flow, flooding, what we call as. So for that, separate scoring is there. So total score you calculate, more than 200 indicates significant bleeding. Okay.
Okay.
Okay. That is one more thing in this. Okay, now you go for next one. So anytime you describe a menstrual cycle, you have to describe the whether it's regular or irregular, what's the duration of flow, days of flow, then how is the flow. Okay. Okay. We'll just know what is normal cycle, then we'll go for the abnormal. Anyhow, we are dealing with abnormal. Just describe how is a normal cycle.
The normal menstrual cycle, it lasts around, it can be up to 21 to 35 days. Initially, you have
21 to 35 days is this is little older concept. Presently, we consider 24 to 38 days as normal. Okay,
Okay.
24 to 38 days. It's been updated everywhere now.
Okay.
Okay.
Initially, you have the proliferative phase where
No, only menstrual cycle you describe. So you describe the frequency. Frequency is 24 to 38 days. Less than 24 is very frequent cycle. More than 38 days is infrequent cycle. Coming to regularity, how will you describe the regularity of menses? When you say a cycle is regular or irregular, how will you describe whether the cycle is regular or not?
if it is occurring after a particular day.
The variation of 2 days, is it abnormal?
No, sir.
4 days?
No.
10 days?
I do not know, sir.
Okay. Variation of 2 to 20 days is normal. Okay. Variation of more than 20 days we consider irregular cycle.
Okay.
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 Then how about the duration of flow? What is the normal duration of flow?
It lasts for around 4 to 7 days.
From 4.5 to 8 days. Okay. So initially they used to take 4 to 8 days. Some take 4.5 to 8 days. More than 8 days you consider prolonged cycle. Less than 4.5 days you consider shortened cycles. What about the volume of flow?
I do not know, sir.
So 20 to 80 ml is normal flow. More than 80 ml is heavy flow. Less than 20 ml is a light flow. Okay. For all viewers, there is a management guidelines of abnormal uterine bleeding in reproductive period by FOXY, a handbook, small, some 4 to 6 pages handbook, which covers full AUB in detail. Okay. In the sense, it's very concise, but it covers each and everything which you should know. Okay, so this is about the normal menstrual cycle. Okay, so frequency 24 to 38 days, regularity.
Can you please repeat the book's name? Abhilash?
No,
Management of
we
AUB.
can discuss. We can briefly tell it to the students so that they don't have. I don't think they have so much time to read guidelines.
No, this is not exactly a guideline. This is a handbook which
I know.
gives all the details.
Yeah, the PALM-COEIN classification and
yes,
subsequent
so go
management.
through the book. It's complete. You will know the full management of AUB. Okay, it's just a few pages book. Okay, we'll go next. Dysmenorrhea. I think I will describe dysmenorrhea.
Abhilash, we are joined by, that was Dr. Mangala. Okay, Mangala.
Hi, Mangala.
Who has joined us.
Hi,
Long time.
Abhilash.
Yeah.
No, I
Anyway,
joined 10 minutes
carry
back.
on, okay.
I was just listening.
Okay.
Okay.
Yeah. The
Please, and
dysmenorrhea description.
Abhilash, one request. Any important
Yeah.
points which they should, please stress on that and please repeat them, please. Especially that
Okay, sure.
periods, durations, and what is prolonged, what is heavy. These are very important Viva questions. Please repeat them and tell that book's name again, whatever you want to tell. Okay, I didn't get book's name.
It's Management Guidelines of Abnormal Uterine Bleeding in Reproductive Period by Foxy. Available online PDF is there.
Fox. FOX.
We'll
Fox.
share it in the group. We'll
Foxy.
share it in one of the
Foxy.
groups.
Okay.
Yeah.
We'll
that's
share
right.
it.
Please send me. I'll post in the groups today.
Yeah.
I'll post in the WhatsApp groups. Thank you. Please continue.
Okay.
Sorry for interruption.
Yeah. No issues. Yeah, dysmenorrhea.
Yes, sir.
Describe the dysmenorrhea.
Hello.
Yes,
Hello.
continue.
Yeah.
Describe the dysmenorrhea. He told to describe the dysmenorrhea.
The dysmenorrhea is she also complains of pain during menstruation since 6 months, and it usually aggravates on during menstruation, that is 3 to 4 days before menstruation, relieved on medication, and it also reduces after the stoppage of bleeding.
Okay. So, what are the types of dysmenorrhea? Types of dysmenorrhea?
Congestive and secondary.
Okay. So, what
Both
type
are
of
same.
dysmenorrhea is this?
This is secondary.
This is secondary. Okay. So, patient is from Mangalore. What do you think? Can be the
Hello?
cause? Hello? Can you hear?
Yes, sir. Yes, sir.
Hello? Okay. Patient
Hello?
with, hello, 26-year-old unmarried with dysmenorrhea hailing from Mangalore. What
Yes,
can
sir.
be a probable diagnosis?
My most probable diagnosis could be towards endometriosis.
Good. Okay. So,
Or
our
it-
Kerala and Mangalore comes under the endometriosis belt. We commonly encounter in this age group endometriosis. So, what is triple dysmenorrhea?
I'm sorry, sir. Can you repeat it?
Triple dysmenorrhea.
I do not know, sir.
So, what you see in endometriosis and adenomyosis, you can see triple dysmenorrhea. That is before, during, and after. All the 3 periods, you can get the dysmenorrhea. Okay. So, just if you know, can tell about the terrible triad of endometriosis or adenomyosis.
It is dysmenorrhea, dyspareunia, and menorrhagia.
Dysmenorrhea, dyspareunia, and
Menorrhagia.
it's infertility. Okay. So, these 3 constitute the terrible triad. Okay. Can go ahead. Come to the negative history. Why you asked each specific negative history?
There is no history of abdominal mass. This was asked to rule out fibroids or leiomyoma.
Okay.
There is no history of burning micturition, increased urinary frequency, or urinary retention. This was asked again to rule out the pressure symptoms of fibroids, or also to rule out any endometrial infection like chlamydia. And there is no history of constipation, again to rule out the pressure symptoms. No history of vaginal discharge to rule out endometrial infection. No history of fever or cough. This is to rule out genital tuberculosis. And no history of significant weight loss. Though it is very rare, this was to rule out malignancy.
Why malignancies are rare? Okay, in this
In
age
the age group,
it's rare.
yes.
Okay. So, what will be the tuberculosis presentation usually, commonly?
Genital tuberculosis, sir.
Yes. What will be the common presentation as in menstrual complaint?
Oligomenorrhea, sir.
Okay. Why?
Mhm. Because of the adhesions formed, there will be a restriction of the
Okay.
outflow.
Okay. Okay. Go ahead with that.
The previous menstrual history, last menstrual period was on 7th of April 2020. She attained menarche at 12 years of age, and she had regular cycles of 28 to 30 days. She uses 3 to 4 sanitary napkins per day, and there is no passage of clots, no history of dysmenorrhea.
Okay.
Coming
So
to the
you can add no history of puberty menorrhagia. If there is puberty menorrhagia, what else you can think of?
any hypothalamic pituitary disorders.
Okay. Anything else? From the onset of menarche, if she's having heavy bleeding. And she also has some gum bleeding or anything, some other causes, other symptoms. Can you think of anything else?
Vitamin C deficiency.
It can be bleeding disorders. Okay. So it can be a bleeding disorder. There is a specific criteria to go through how to define a bleeding disorder. That it's okay. It's not required for UG level. Go ahead. Next.
Coming to the past history, there were no history of medical interventions, no history of any surgeries done, no history of diabetes mellitus, hypertension, tuberculosis, asthma, and epilepsy.
What else you should have added? Past history?
Bleeding disorders, sir.
Thyroid disorders. Okay. Thyroid is important for heavy menstrual bleeding.
Okay, sir.
Yeah. And coastal region, again, thyroid disorders are common. So add in the past history. The family history.
Coming to family history, there is no history of any similar complaints in the family, no history of any bleeding disorders, no history of diabetes mellitus, hypertension, tuberculosis, asthma, and epilepsy.
Malignancies you can add here.
Okay, sir.
Okay, good.
Personal history, she consumes a mixed diet and has a normal appetite. Her bowel and bladder habits are normal. She has adequate sleep, and there is no history of any addictions. General physical examination.
Any contraceptive history is there? You should add it there. Any use of contraceptives?
Okay, sir.
Okay, then usually we summarize the history once and keep possible diagnosis in the mind and go ahead with the examinations. Okay.
Okay, sir. Okay.
Can you describe the PALM-COEIN classification of AUB?
PALM-COEIN states the most possible causes for AUP, that is polypus, adenomyosis, leiomyoma, malignancy, C's.
So this PALM will constitute structural causes. COEIN will constitute the
functional causes.
So, yeah.
C is coagulation disorders. O is for ovulatory disorders. Then E is endometrial disorders. I is iatrogenic, and N is non-classifiable.
Not yet specified. Coming to what is the common cause in this age group?
Endometriosis.
Don't keep endometriosis in mind at present. What is the common cause otherwise overall?
Fibroid.
Fibroid at 26 years age, is it likely?
No, sir.
Any younger age group you think of ovulatory dysfunction as the first thing you think of. Then we have to rule out all other causes. But commonly it will be ovulatory dysfunction. Whereas the age advances, they'll go for all other structural causes they have to consider. Okay. Can go ahead with the examination, I think.
Okay, sir.
So in this patient, what do you consider? What do you keep in mind as the diagnosis?
any structural abnormalities, that is polypus, adenomyosis, endometriosis, leiomyoma.
In this patient, I will go for more of functional. Ovulatory dysfunction I'll keep as a first cause. Then of course endometriosis and dysmenorrhea is there, and others we can rule out any. Okay.
Okay.
I think even endometriosis by ovulatory dysfunction only it causes heavy bleeding. You can always keep AUBO as one of the causes. Okay.
Okay, sir.
Okay. Go ahead with the examination.
General physical examination. The patient is conscious, cooperative, and well oriented to time, place, and person. She is moderately built and nourished. She weighs of 52 kg with height of 156 centimeter. Her BMI is 21.3 kg per meter square. Pallor is present, that is, pallor was observed in the lower palpable conjunctiva. There is no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, and no generalized edema.
Okay.
Coming to the vitals, the pulse rate was 72 beats per minute with regular rhythm, normal volume, normal character, no vessel wall thickening, and no radiofemoral delay. Blood pressure was 130 by 80 mmHg, taken from the left hand in the sitting position. Respiratory rate was 18 cycles per minute and thoracoabdominal type, and she was afebrile.
Okay.
Abdominal exam is flat. Position of the umbilicus is central and inverted. The corresponding areas move equally with respiration. There is no scars, sinuses, or dilated veins seen. Hernial orifices were intact.
Okay.
On palpation, there is no local rise in temperature. Tenderness was present in the iliac region on both sides. Abdomen is soft. There is no palpable mass, no organomegaly. On percussion, tympanic note was heard, and liver dullness was heard at the right fifth intercostal space. On auscultation, bubble sounds were heard.
Okay.
Other systemic examination, cardiovascular system, first and second heart sounds were heard, no murmurs were heard. Respiratory system, vesicular breath sounds were heard, no added sounds. Central nervous system.
You have missed some negative history, Neha.
Yes, ma'am.
Yeah, like intermenstrual bleeding, postcoital bleeding. Okay, no, not
Unmarried.
postcoital. She is unmarried. So intermenstrual bleeding.
Okay, ma'am.
Yeah, that also you have to mention.
Okay. Possible diagnosis.
Any other premenstrual symptoms she has? No.
No.
No, only dysmenorrhea she described. I think.
Okay, only dysmenorrhea. Okay.
Yeah. Yeah. Possible diagnosis. AUB. Which AUB?
Oh, sir.
Okay, AUBO with differential diagnosis. You can give other PALM-COEIN also as differential diagnosis. And here we'll be ruling it out. Okay, which one test you want to do immediately now?
Ultrasound.
Prior to that, anything else?
Immediately in your clinic.
Speculum examination.
Okay, good.
Unmarried, no?
Sorry.
Okay, any other case when there is a married woman, you please tell you wish to proceed with perspiculum and pervaginal examination. Since she is unmarried, we may not do perspiculum and PV examination. As you say, we go for scan, but prior to that, anything else you want to rule out? Any reproductive age group with heavy bleeding, what do you want to do?
We need to take a complete blood count and rule.
Any reproductive age group with heavy bleeding, what do you want to do? I specified reproductive age group.
Sorry, sir.
Any reproductive age group with heavy bleeding, what you want to rule out first?
Considering she is
Pregnancy, sir.
Yeah, so first UPT you have to do. Okay.
Okay.
It's mandatory in all reproductive age group, whether married or unmarried doesn't matter. So we don't know. So better to do one UPT. Once negative, you proceed with the rest of the investigation. So what are the investigations you wish to do?
Investigation first, complete blood count, and then later on other investigations can include ultrasound.
Okay, you classify the investigations like to confirm the diagnosis, to know the complications, and as a pre-operative workup, so that it will be easy for us to understand why you are doing each investigation. So to confirm the diagnosis, what you want to proceed with?
Ultrasound, sir.
What ultrasound?
Abdominal ultrasound.
Complete. Yeah, transabdominal ultrasound. So what you want to look for in ultrasound?
We have to look. You have to rule out if it is caused by a fibroid, or you have to rule out if it is.
Okay, so you will see the structural causes.
Yes,
that
structural
is,
problems.
any fibroid, any endomyosis, you will see in the scan.
Then we can do thyroid function test.
No, in the scan only that structural cause you'll see. Anything else you want to see?
The thickness of the endometrium.
Very good. Why you want to see the endometrial thickness? So what is the cutoff of endometrial thickness taken to be normal? Sorry, so many are writing 4 mm. That's for postmenopause.
I do not know, sir.
12 mm is taken as the cutoff. More than 12 mm, you have to evaluate. Okay. What else you'll see? Suppose there was a polyp. What is a better diagnostic modality or imaging modality?
what type of ultrasound?
Transvaginal.
No,
saline infusion sonography. Okay, saline infusion sonography is a better modality for any intracavitary mass will be delineated. So suppose fibroid is there, how will you classify the fibroid?
We classify them as intramural, subserosal, and submucous.
Do you know about FIGO classification of fibroids? Have you heard of 0 to 8? Okay. 0 will be your submucosal, entirely submucosal fibroid. Fibroid polyp. 1 will be submucosal fibroid, which is less than 50% intramural. 2 will be more than 50% intramural. 3 will be totally intramural fibroid, which is indenting on the endometrium. And 4 will be entirely intramural fibroid. 5 will be subserosal with at least 50% intramural. It's there in your same PDF. Okay, it's commonly used. Now we are following this FIGO classification, and based on the type of fibroid, we can know what symptoms it causes. Okay, so your submucosal up to I think 6, it can cause heavy menstrual bleeding, whereas beyond 6, it causes more of pressure symptoms. Okay.
Okay, sir.
That's about the leiomyoma. Okay. Other than ultrasound, what else?
We can do a dilatation and curettage, and then a biopsy as well.
Wait. Dilatation and curettage. Why? You tell about the other investigation, the simple blood investigation.
Yes, complete blood count, coagulation timings, then thyroid function test.
Okay. That's all. Okay. So when will you go for the endometrial sampling? Indication for endometrial sampling.
I do not know, sir.
No, you told no dilatation and curettage you want to do. So when you want to do a dilatation and curettage, or when will you go for endometrial sampling? There are various methods of endometrial sampling which we'll further discuss. So when will you do endometrial sampling?
Bleeding in an elderly female, maybe postmenopausal female.
Postmenopausal bleeding is entirely different case presentation. We'll stick to the heavy menstrual bleeding.
Okay, sir.
So when you want to do in heavy menstrual bleeding, when you want to evaluate endometrium?
When you suspect any malignancy.
That's the same question. When will you suspect a malignancy in heavy menstrual bleeding?
If there is a positive family history.
Okay, when there is a positive family history. You told something elderly, no?
Elderly females.
Yeah, what is elderly?
That is above 40 years of age.
Okay, above 40 years, any heavy bleeding, you have to do endometrial sampling. Okay, below 40 years, when will you do any heavy bleeding? Above 40 years, you will go ahead with the endometrial sampling. Less than 40 years?
You do.
Less than 40 years, there are specific indications when you have to go ahead with the endometrial sampling. Like when patient has a positive family history, or when endometrial thickness is more than 12 mm, or when she is a high risk for endometrial carcinoma, such as obese patient, PCOS, prolonged anovulation, on estrogen therapy, on tamoxifen therapy. So all these are the indications for endometrial sampling. In these patients, when there is a high risk for suspecting malignancy, you have to go ahead with the endometrial sampling. Okay.
Okay, sir.
So how will you go ahead with the endometrial sampling? This is a common method used in your hospital.
The dilatation and curettage.
Sure, Mangalore is advanced. We follow PIPEL, no?
Yes.
So there is office biopsy and your inpatient biopsy. So office biopsy we follow is endometrial PIPEL. How will you do? Have you seen endometrial PIPELing procedure?
No, sir.
No. Okay. It's a very thin tube, 3 mm in diameter. You know, ours is usually 3 mm. It's always open, so we can easily negotiate it through the ours, and we create suction. By screwing movements, we retrieve the sample. Some say it's more accurate because it works through vacuum. It's more accurate than dilatation and curettage. It has good sensitivity and specificity. That's the first procedure usually we do. If we don't obtain sample in endometrial PIPEL, then we consider to go ahead with the operative setting, that is hysteroscopy and endometrial biopsy. Usually we do, because there can be a focal thickening sometimes. Okay.
Okay.
So what information you get by doing this endometrial sampling?
We get the histopathology. We can look at the type of cell or the type of structures.
Yeah, what are the
endometrial?
What are the histopathologies you can get?
Yes. If it's an endometriosis, then we see the presence of endometrial glands, and
it can be a normal. It can be a normal endometrium corresponding to the period patient is in, proliferative or secretory endometrium. It can be disordered proliferative endometrium. Suppose patient is in secretory phase and you get a proliferative endometrium, then it's a disordered proliferative endometrium. Then we have hyperplasia. Okay. So how will you classify hyperplasia? Recent 2010 WHO classification.
I don't know, sir.
Hyperplasia is classified as hyperplasia without ATPI and hyperplasia with ATPI, right? Previously, we had simple hyperplasia with ATPI, simple hyperplasia without ATPI. All these 4 classifications were there. They are now clubbed and made hyperplasia without ATPI and hyperplasia with ATPI. Say any AUB case, young age, they will go for ovulatory dysfunction. Little older age, usually they go for either structural causes, can be fibroid, adenomyosis, or they will go for hyperplasia. Okay.
Okay, sir.
In exam, usually they go like that, and usually they get bored towards the end. Numbers which are coming towards the end, AUB randomly they pick one of their choice topic and they go for that specific question. Endometrial hyperplasia means they will go entirely into the endometrial hyperplasia. It's important for you. Endometrial hyperplasia. Okay. Fibroids are important. We usually don't go towards coagulopathy in UG level, and definitely endometriosis in this region is commonly asked question because a lot of patients we get with endometriosis. Okay.
Okay.
Okay. So we'll go one by one. So first we'll consider ovulated dysfunction. So we have already discussed what are the investigations done, when to do endometrial sampling, and other investigation modalities we have seen. Okay, don't forget UPT to rule out the pregnancy
Yes.
complications. Okay, we'll go one by one. Polyp, how will you diagnose polyp and how will you treat the polyp? What will be the bleeding? How will be the bleeding in polyp, endometrial polyp?
Endometrial polyp can be postcoital, usually causes postcoital bleeding.
Okay, can be prolonged uncontrolled bleeding, intermenstrual bleeding can be there, postcoital can be there if polyp is protruding to the os. What's the treatment?
Hysteroscopy, which is both diagnostic as well as therapeutic. So.
Okay. Polypectomy, simply we can do a polypectomy or hysteroscopy guided polypectomy also can be done. Okay. How will you treat adenomyosis? Coming to second one, adenomyosis. What's the characteristic feature?
Adenomyosis is usually it occurs in women above 40 years of age. And
your same patient, heavy bleeding and dysmenorrhea, if she was around 30 or above 30 years old, I would have considered adenomyosis as with multiparous women, I would have considered adenomyosis as one of the differential diagnosis. Okay. So
uterus is usually enlarged, sir, symmetrically enlarged.
How? Yes, symmetrically enlarged and it will be tender. Okay, so that is the characteristic of the adenomyosis. So how will you treat adenomyosis?
You can diagnose it with ultrasound or MRI.
Yes.
And treatment is usually total hysterectomy, sir.
No. First, 30-year patient you want to do hysterectomy?
No. If it is elderly.
35 years and all?
No, sir. You can start with medical treatment.
Which medical treatment?
You can have danazol or GnRH.
Okay. In OBG, heavy bleeding, you don't know anything, you utter progesterone, it will always be correct, okay? Usually it will be correct at least. So for adenomyosis, we consider LNG-IUS as the first line treatment, levonorgestrel using intrauterine system. Then we can, like hysterectomy at the last, usually they respond to LNG-IUS very well, okay?
Okay.
So coming to fibroid, how will you treat the fibroid?
Fibroid, you can initially start with the medical treatment in order to control the anemia and to reduce the size of the fibroid. And later on, you can do a myomectomy.
Yes, myomectomy or depending on the age, hysterectomy can also be planned. This general medical management, I'll come again at the end. I'm going by specific lesions. What is the treatment? Okay. So malignancy, how will you treat? So your PALM-COEIN, I'm at M. Okay. We discussed polyp, adenomyosis, leiomyoma. Now M. M contains both malignancy and. What's the one more thing?
Malignancy.
AUBM contains what and all?
People in chat section are replying.
Yeah.
Pre-malignant.
No, before that.
Prior to that, there is, yes, endometrial hyperplasia. Okay, so it contains endometrial hyperplasia as well as malignancies. So how will you treat hyperplasia? Since hyperplasia is very important for you, I'm again and again coming back to hyperplasia. It's not DNC. DNC is how you diagnose. How will you treat hyperplasia?
Yes, again somebody in chat section has replied.
Chemotherapy you got.
No, not that.
No.
Before.
Okay. Hyperplasia depends on what hyperplasia it is. Hyperplasia without atypia or hyperplasia with atypia. Whenever hyperplasia is with atypia, it will progress to malignancy very fast. It has very high rate of developing a malignancy. And they say sometimes malignancy will be hidden within hyperplasia. Okay, so better to go ahead with the hysterectomy. Whereas simple hyperplasia, and also in some people, hyperplasia with ATP in young age, very young age group patients who want to preserve their fertility function, you can go ahead with the progesterone. So remember, progesterone is usually anywhere heavy bleeding, can give progesterone confidently as answer. Okay.
Okay.
So again, LNG or US you can use, or oral progesterone you can use. Methoxyprogesterone acetate 10 mg you can start with. Then you have to follow up with the endometrial sampling. Okay. We should know at least this much in the...
Progesterone is so effective that it is called the medical curettage, medical method of curettage. You know, DNC, there are two benefits. One is diagnostic, another is therapeutic. People who don't respond to medical management, when you do a therapeutic DNC, thoroughly curate the endometrium, that itself helps them. So similarly, progesterone is medical curettage. Okay. Yeah, continue.
Okay, so remember at least to answer this much: progesterone and hysterectomy for endometrial hyperplasia. Young, simple, hyperplasia without ATP, progesterone. With ATP, hysterectomy. Okay, you'll remember this much, no?
Yes.
Yeah, don't get confused in the exam.
Okay.
They'll definitely come to hyperplasias at some point of time in this AUB presentation. Okay.
If she has completed family, then it's hysterectomy.
Yeah.
If she has
and with
not,
ATP, usually suggested.
Yeah.
We'll come to the most probable cause in this case, ovulatory dysfunction. How will you treat?
Ovulatory dysfunction mainly through medical management.
Yeah. So what is that medical management?
The selective estrogen receptor modulators.
Why? No.
Progesterone.
Yes, progesterone to control the acute bleeding. After that, you want to go ahead with? How will you regularize the cycle? Oral contraceptive pills you can use in these patients, okay? But for acute bleeding, you have to use progesterone. That will not control, OCP will not control your acute bleeding episode. You start with the progesterone, tapering dose. Usually we start TID, then BD, then OD. For 21 days we cover. Then we go ahead with the OCP. Okay. So what is AUBE?
Endometrial causes.
Like
tubercular endometritis or any infection like chlamydial infection.
They all come under not classified. So this AUBE is our old DUB, okay? When we never used to get any cause and we put it as DUB, assuming bleeding is because of the progesterone. There is imbalance in the progesterone at endometrial level that causes heavy bleeding, then we put under AUBE, okay? Okay, that covers all the causes. And what is the common cause for ovulatory dysfunction? Especially if she had amenorrhea followed by heavy bleeding in young age group.
The axis has not yet stable. Polycystic ovarian.
What can be the cause? Yes, polycystic ovarian syndrome is also very common nowadays. So that can also be a cause for it. Okay, I think we discussed almost all the causes. So can you tell in brief about the medical management of heavy bleeding?
Okay, sir. First, you can have combined oral contraceptives or progestogens. Progestogens is usually...
Start with a non-hormonal, then go for the hormonal.
Non-hormonal is first to correct the anemia, and you can use Mirena IUCDs.
Mirena IUCD is hormonal, no?
Okay.
Okay, you can see in the comment section, so many they are writing.
And non-steroidal
Yes. Anti-inflammatory drugs. Then
antifibrinolytic
tranexamic
agents.
acid. Yeah, tranexamic acid. 8 times delayed. We commonly use this, no? Pause is used left and right. Okay, so uncontrolled with this treatment, then we'll go ahead with
hormonal treatment.
Yeah, hormonal. What hormonal treatment we use?
Progestogens, that is the main hormone.
Yeah, which progesterone? How much we use?
We use 5 to 10 mg first initially, and then you continue with the initial high dose is 10 to 30 mg. That will arrest the bleeding, and later on you continue with
we taper.
We taper.
We taper the dose.
Yes.
So which progesterone we use? Name?
We can use norethistron or DMPA or LNG.
Okay, we use orally.
Hello.
Yeah, we use commonly this one, the medroxyprogesterone oral or norethistron, as you told. Then your DMPA injection and LNG is like they're the different ones. For acute control, we use these two oral. Okay.
Okay.
Then specific lesions, we can go ahead with any of the treatment. DMPA. What is the problem with DMPA injection?
Side effects.
There will be regular spotting. Okay, we have to tell them there can be a spotting is okay. Like that can be a common complication of DMPA injection. They should not worry about that. Otherwise, they will keep coming to you. They're still having bleeding like that. Okay. It will control heavy bleeding, but they can be spot. And DMPA injection, what is the dose and how much you give? Once in how many months you give?
I don't know, sir.
Both ways. 150 mg you give once in 3 months. That's about DMPA. Okay.
Then we can use GnRH analogs.
Okay. What is pseudo pregnancy? What is pseudo menopause? So menopause, like environment is created by which injections? Just mention no GnRH analogs. So they call menopause like GnRH analogs also. Then pseudo pregnancy is caused by progesterone. Okay. Yeah. So GnRH analog, how much you can give?
It can give around 3.5 mg every monthly. That is a depot injection.
3.25 for how long?
For around 6 months.
Okay. Why not prolonged use?
That will cause anti-estrogenic action and have menopausal symptoms and other adverse effects.
Okay, so we cannot use GnRH analogs for a prolonged time, so we don't use it for a prolonged time. Okay, osteoporosis is yes, causes osteoporosis. Also, usually we supplement more than 3 months. We start supplementing with calcium also. We'll not use it for more than 6 months. Okay. What are this?
Other drugs are selective estrogen SERMs like ormeloxifene.
Yeah. How we use ormeloxifene?
It's around 60 mg. We give it for 6 months.
I think it's started with twice weekly. Then we go ahead with once weekly. Okay. What is the brand name we use? Like Government of India subsidized rated. Given no.
Centroman.
Centroman. Brand name. Then Chaya it is. Chaya. Okay. Chaya.
Okay, sir.
Chaya, Saheli, both are correct.
Saheli, both are there. What about DMPA? Government of India supply? Yes,
That's it.
Antara. Okay. Antara is DMPA injections provided by Government of India. Okay.
Okay.
Should know about all this. May not come in AUB, may come in some other sections. Okay. So that's about the medical management. Suppose it comes as AUBE or your old DUB. Okay. Is there any minimally invasive surgeries we can go ahead with?
We can do ablative techniques.
Endometrial ablation we can do. So the disadvantage of endometrial ablation?
Can you repeat it, sir?
What is the disadvantage of endometrial ablation?
Disadvantage is that fertility is lost.
Okay. Anything else? If malignancy is there, it's also lost. We don't know. Endometrium is destroyed. Right? We cannot diagnose any malignancy, hidden malignancy. It's always dangerous. So what are the risk factors for malignancy in heavy bleeding? The same thing which I already discussed. Can you repeat all the risk factors?
One is if the female is elderly. Another one is if there's a positive family history.
Okay. Which positive family history will increase the risk of endometrial malignancy? Whether it should be only endometrial carcinoma or any other cancers also
breast cancer.
Breast cancer as a part of Lynch and breast cancer as a part of. So your breast cancer is commonly associated with ovarian cancer, right?
Yes.
Then what other cancer? What is Lynch syndrome?
It's also this hereditary non-polyposis colorectal cancer.
HNPCC colon, that is commonly associated with the endometrial cancers. Okay. Okay. Go ahead. First, your family history, age more than 45 or 40 years. Then endometrial thickness of more than 12 mm.
More than 12 mm. Then if there can be also history of OC pill intake.
OC pill will not cause. OC pills contain both estrogen and progesterone, which are counteractive, right? Unopposed estrogen action is predisposing to endometrial cancer, not combined.
Yes.
Then
if the woman has nulliparous.
Nulliparous, good. Then
and if there is no history, if there is reduced history of reduced breastfeeding.
Okay.
Early weaning.
Okay. PCOS, anovulator cycles like PCOS, infertility. Okay. All these other risk factors, obesity, diabetic and hypertensive. You know what is corpus cancer syndrome? You should be knowing. Corpus cancer syndrome is metabolic syndrome along with endometrial CA. So anyone who is diabetic, hypertensive, obese are more so predisposed for endometrial cancer. Okay. Okay. Anything else to discuss? You want to know? Anything we missed? Okay, endometriosis. You were giving the diagnosis of endometriosis, right? So
Yes.
how will you treat endometriosis?
Endometriosis. Initially, you can treat it with the medical management like NSAIDs. Then you can you can start with the drug treatment like progestogens.
Yes, progesterone causes pseudo pregnancy-like state. Endometriosis is usually controlled.
Then, if the medical management does not work, then you have to do the minimal invasive surgeries.
Okay, like we go ahead with the laparoscopy and laparoscopic ablation of all the lesions, if peritoneal lesions are there, or we can do cystectomy if you have chocolate cyst in the ovaries. Okay.
For endometriosis, before treating, you have to ask what, I mean, in this patient it is pain, but in general you have to ask whether it's
Okay.
Hello.
Hello.
Yeah, can you hear? That's what symptomatic treatment. If pain, we go ahead with all this. If infertility, it's different. The treatment entirely differs. There is no role of medical management for infertility. Okay. So pain usually usually adolescent endometrial is very common. We find lot of ovarian cysts, chocolate cysts. So we go with the there will be a lot of huge cysts. So we go ahead with the surgical treatment, but should be managed very carefully because they are adolescent. Also, you can use GnRH analogs for endometriosis. Actually, can you hear?
Yes, sir.
Okay. That's about the endometriosis. I think
And in a married patient, as you told, PV perspective and PV examination, you have to also take a pap smear.
yes, pap smear is important. Anything else to discuss, Mangala? We covered all.
Yeah. They might ask you about the definition of DUB. I mean, not used much, but still, it's good to know. Do you know the definition of DUB?
Ma'am, is it the same as AUB only, or I'm little confused between that DUB and AUB? How are they different, or are they the same?
AUB is the term used now. He told when no other cause is identified, it is
That's
DUB.
what AUBE you can put as DUB. That what represents your DUB. DUB is old term.
Yeah.
You should know about metropathia hemorrhagica also, because our examiners are not that young. No, they're not updated regarding all this. They keep asking about DUB and metropathia hemorrhagica. I've seen they'll ask about all this.
DUB you can define as abnormal uterine bleeding in the absence of palpable pelvic pathology. Any organic pelvic pathology. Okay. So it is classified as ovulatory and anovulatory. So PCOS comes under anovulatory DUB.
Okay, ma'am.
Okay, someone is asking, I think chat, there are a lot of questions. Okay, why there is oligomenorrhea in hypothyroidism and menorrhagia in hypothyroidism? Can anyone explain how hypothyroidism causes thyroid dysfunction causes menorrhagia, AUB? Hello?
Hello.
Yeah. So why hypothyroidism causes menorrhagia? What classification it comes under?
In PALM-COEIN classification, sir.
Yes.
It comes under AUBO, sir.
So it causes by ovulatory dysfunction. Why it causes ovulatory dysfunction?
It disrupts the GnRH secretion and LHFSH levels that disrupted.
Its similarity to TSH has a similarity to which are the hormones which share same alpha subunit?
HCG.
Yes.
TSH.
Yes.
And FS.
Yes. So because of the same mechanism, see, you get hyperthyroidism in molar pregnancy, right?
Yes.
Similar mechanism applies here. Hypothyroidism get menorrhagia, okay? Because of the impairment in the FSH. Hyperthyroidism is that metabolic state because of which there is the proliferation of endometrium. That is one of the cause for hypomenorrhea in hyperthyroidism. Okay. Then
What is the difference?
Metropathia hemorrhagica, you can go through in the book, even in all the books, Metropathia hemorrhagica, there is various patterns, and there's a question also for you, usually 5 marks they'll have.
Okay, what is the, I mean, why does excessive menstrual blood clot? The passage of clots indicate excessive menstrual bleeding, right? Why is it so? Why does it clot when it is excess?
In other words, why menstrual blood usually don't clot?
Yeah. In chat section, some people are replying. It's because of the lytic system. It dissolves the clot. Okay, when the bleeding is in excess, it's not able to complete it. Outruns the fibrinolytic system, the amount of blood. So it comes as clot. It is not able to get lysed. You understood?
Yes, ma'am.
So what is the difference between progesterone breakthrough bleeding and progesterone withdrawal bleeding?
There are 4 entities: estrogen breakthrough bleeding, estrogen withdrawal bleeding, progesterone breakthrough bleeding, progesterone withdrawal bleeding. The difference between different. Have any idea?
What happens in normal menstrual cycle? What bleeding is it of? What?
Because of the reduction in the progesterone levels, the bleeding occurs.
So it is called
Progesterone withdrawal.
Yeah. So the normal. Yeah.
You think it in a very simple way. So estrogen causes building blocks. Bricks you build wall, no? So your estrogen is the one which builds the keeps on building the bricks. So when we keep on building the wall with bricks, it's not stable, right?
Yes.
Progesterone provides that stabilizing, cementing factor. Okay.
Okay.
So for a wall to be stable, both you require estrogen to build the bricks, and to stabilize with the cementing material, progesterone is required. If there is no progesterone, you suddenly withdraw the progesterone, estrogen will keep it on building, and it's unstable and it will fall. That is, there will be heavy bleeding. Okay. That is shedding of the endometrium happens. You understood the analogy, no?
Yes.
Yeah, it's like that. So based on that, you can describe any type of the bleeding. Okay. So progesterone breakthrough is when estrogen is excess than the progesterone. Progesterone is not able to provide enough cementing material. Estrogen is goes on building the brick wall. So it suddenly falls and there is bleeding. Okay.
Okay, sir.
So withdrawal is when the hormone is just taken away. Like progesterone withdrawal bleeding just before menses. Progesterone secretion stops and bleeding occurs. So progesterone breakthrough bleeding is when you continuously take progesterone pills for a long time. Like he said, no, DMPA, that is depot progesterone, can cause spotting. So that is called progesterone breakthrough bleeding.
Okay, ma'am.
And estrogen breakthrough bleeding occurs in PCOS. In PCOS, ovulation does not occur. So progesterone is not produced. So continuously estrogen keeps on building up the endometrium. So at once when it's very thick, it comes out of the blood supply and suddenly starts shedding. So that is estrogen breakthrough bleeding. Like there is continuous estrogen, and at some point the endometrium just breaks. Okay.
Okay, ma'am.
Estrogen withdrawal bleeding is like following oophorectomy, no, Abhilash?
Yeah, following oophorectomy.
And also the mid-cycle bleeding that can occur. Sometimes during ovulation, some people may have spotting mid-cycle. That is called Mitchell-Merz. Okay. Estrogen withdrawal bleeding. So these are the 4 types and 4 examples.
Okay, ma'am.
Okay, so shall we wind up the session? We'll go on concluding. How to come to a diagnosis? Can you briefly tell?
The investigations done.
No, you have to, from history level, you have to keep the age in mind.
Okay.
So
History.
younger age, most common will be ovulated dysfunction. As the age advances, we have all the other causes.
Yes.
And whenever there is a heavy bleeding with any high risk factors or with advanced stage, we have to rule out malignancy. Okay, this much you keep in mind and go ahead with your presentation. Okay. So investigations to confirm the diagnosis, you'll go ahead with the ultrasound, thyroid levels, and to know the complication, hemoglobin level, you have to check whether she's anemic or not. Okay.
Yes.
And as a pre-operative investigation, rest of the investigations you can put ahead. Always do UPT to rule out pregnancy related complications since they are in reproductive age. Okay. That's about the investigations. Then management depends on what diagnosis you have arrived at. In general, you can always say non-hormonal medical management, then hormonal medical management, then surgical management. Okay.
Okay.
And read thoroughly about your structural causes. Commonly, you may get any mass per abdomen along with heavy bleeding. Then the case goes in fibroid and all this way. So you have to read fibroid anyhow, it is a separate case also for you. Then read about endometrial hyperplasia, which commonly people miss because nowhere it shows up in your diagnosis. You miss it. So they suddenly ask about endometrial hyperplasia, you get confused.
Okay, sir.
Really, they can go ahead with endometrial carcinoma if they get bored towards the end, last numbers. They're really, they have finished all AUBs. They are left with malignancy. They'll go with the endometrial carcinoma. Briefly read about that also. Be prepared for endometrial carcinoma. But usually it will be a separate case. Okay.
Okay, sir.
Here in Mangalore, we keep all CA cervix, CA endometrium. For the exams are kept. Also CA ovaries. Because we are very commonly we get all these cases. Okay. Then ovulated dysfunction, and you should know regarding.
And you should
You
know
don't know
regarding
anything blindly,
the
you
new
can say.
terminology. You should know
New
regarding
terminology,
the
PALM-COEIN.
terminologies like heavy menstrual bleeding and opposite is scanty menstrual bleeding, and frequent cycles and infrequent
Prolonged
cycles, prolonged cycles, prolonged heavy menstrual bleeding commonly seen. Yeah, Neha, you were asking something.
Yes, ma'am. I want to add a doubt. If the terms like polymenorrhea, oligomenorrhea, all of them are now not considered.
New guidelines say that we should use the new terminology to avoid confusion. It's easy for you also. The newer terminology, it's easier than the older one.
Okay.
Only old terminologies which they may ask is menorrhagia.
Okay.
Yeah, that is, it may either prolonged or heavy, both come under menorrhagia.
Yes, ma'am.
Okay.
Okay, thank you. It was a nice presentation.
Thank you,
Thank you,
Abhilash.
sir.
Everyone.